peer support and essential workers during COVID-19 online event. And Florence is going to be leading our roundtable. So I'll be turning things over to her shortly. But first, I just want to go through a few housekeeping items. As I said before, participant microphones are muted at entry. So please use the chat box if you have any questions or technical difficulties, and we can help you out with that. This session is being recorded, and it will be available on the MHTTC website within 24 hours of the end of the presentation. If you have any questions about the topic during the webinar, feel free to use the chat box. Information about certificates of completion will be sent in a follow-up email within 24 hours of the end of the presentation. And yeah, so if you have any questions, feel free to send us an email at newengland@mhttcnetwork.org. So our team with the MHTTC is sponsored by Yale University for Recovery and Community Health in partnership with C4 Innovations, Harvard University, Department of Psychiatry, and Center for Educational Improvement. So our mission is to use evidence-based means to disseminate evidence-based practices across the New England region. So our areas of focus are recovery-oriented practices, including recovery support services within the context of recovery-oriented systems of care. So we're working to ensure inclusion. So to ensure the responsiveness of our work, we will actively develop and maintain a network of government officials, policymakers, system leaders, administrators, etc., from each of the 6 states of New England for MHTTC's activities. So we encourage you to participate in the chat, ask questions, comments, share your experiences so that we can have a lively discussion today. And if you would like to follow up with us, we have a Twitter and a Facebook, so feel free to follow us, retweet us, like and share, and interact with us. So yeah, so if you have any more information, please visit us at mhttcnetwork.org/New England, and our information is below, in the pod below the PowerPoint slides. So with that, I'm going to hand it off to Anna.
Thank you, Adrienne, and good afternoon, everyone, and welcome to the last of a series of 3 webinars that we offered. These are part of a project called Sharing Our Wisdom, Lived Experience in COVID-19. The Wisdom Project, which is a project I lead, was made possible by a partnership between the Yale Program for Recovery and Community Health and the New England MHTTC. We brought to you a series, or we will bring to you a series of 7 podcasts, and we brought to you already 2 webinars, and this is the last one of the series. So we met for the past 2 weeks to talk about mental health, social justice, equity, and COVID-19. The initial question that motivated the series is, what can people who have had mental health challenges uniquely offer by virtue of their lived experience of recovery? This entire project was organized and invites people with lived experience with mental health and substance use challenges. We want to share our wisdom on what has helped us in these difficult COVID times. So I'll be monitoring the chat throughout our conversation, and we encourage you to engage with us, ask questions, make comments, and we'll have time for Q&A after our roundtable. So make sure that you put in the chat things that have struck you and questions that you might have for our participants. Before we start, I'd like to take a moment to thank our program director at the New England and the New England MHTTC director, Larry Davidson, for his support, and my colleagues who make this work possible, Thomas Wexler, Claire Bien, Pauline Bernard, Kendall Etterbury, and Keris Myrick. There are many others who are part of this, and I can't name them all, but thank you very much. Without your energy and support, none of this would have been possible. So without further ado, I'd like to introduce our panelists for today's conversation. First, I'd like to welcome Keris Myrick. She is the Chief Peer and Allied Health Professions for the Los Angeles County Department of Mental Health. Keris is a leading mental health advocate and executive known for her innovative and inclusive approach to mental health reform and the public disclosure of her personal history. Welcome, Keris.
Thank you.
Thomas Wexler was born in New Haven, Connecticut. He's a writer, musician, and spoken word poet who performs throughout Connecticut. Thomas has an undergraduate degree in American Studies from Yale University and a master's degree in the same field from Bowling Green State University. He was drawn to psychology through his effort to better understand how people's lived experience of mental illness and addiction, such as himself, fit into the cultural landscape. He's interested in finding clinical applications for the cultural representation of mental illness. Welcome, Thomas.
Thank you.
Richard Ewens is a peer support specialist at the Connecticut Mental Health Center. He's also a musician and a colleague of mine at the Yale Program for Recovery and Community Health. Thanks so much for joining, and welcome, Richard.
Hello. Hi.
So our conversation today is about peer work and COVID-19. We've been talking for the past couple of weeks about what can people with lived experience offer in terms of wisdom to everyone, really, during these extreme times. I was wondering, I wanted to start us with the first question. What about the role of peer support workers make them especially valuable in the current pandemic? Did you want to start, Thomas?
Sure, I'd be happy to. I love that question because I think peer workers are especially and increasingly valuable in mental health care in general, and I think that comes into a sharper degree of focus in a time like this, such as the pandemic. And one thing that I try to emphasize about my own experience with peers and also what I believe in about the direction that healthcare is trending and our understanding of mental illness and addiction are trending is that peer workers can preserve a form of normalcy between the patient and the treatment provider. And they can relate to the patient on a level that the patient can understand as indicative of themselves and their cultural identity. And that can facilitate all different types of understanding and treatment options that aren't there when someone takes a strictly clinical view of the patient and their so-called problems. And I think it's incredibly important in a time of crisis when, as we mentioned the other day, reality breaks from us, because those trappings and those indicators and those indices of normalcy are lost to a certain degree. And so where do we locate that crisis? Do we locate it as a clinical phenomenon that needs an abstract and clinical perspective, or do we relocate it back in our common understanding and our common truths and bonds about who we are culturally and in a culturally legible way? And I think the latter is true and needs to be true not just for people with mental illness, but for the broader society and culture at large when facing a challenge such as this.
Thank you, Thomas. That makes a lot of sense. Keris, I wonder if you could bring a systems perspective to that question of the role of peer support right now.
Yeah, I mean, thank you very much for that, like laying that foundation, Thomas. And I think what I would add to that is also because many of us have lived through various types of crises or times when things are just really tough for us, that when we think about this particular time, you know, everybody is going through some kind of trauma and crisis. And we can help people who are not folks who are coming to us normally, if you will, kind of have a better understanding of, yeah, actually, this is the way one ought to be feeling during this time. And, you know, we can get through it. We are certainly examples of folks who have gone through quite a bit, whether it be, you know, through our own mental health and or substance use recovery, whether it is our kind of own working with trauma, experiencing homelessness, living in, you know, residential facilities or even institutions. So that really means a lot different now than it did before because of social distancing and all of that. So from a systems perspective, I think, we've really had to think about not just the people we serve, but we've had to think about every member of our community at large and what role do we help with our community members in understanding those emotions that they're going through during this time and helping them get through those emotions, acknowledging what they are and helping them get through, and being an example that indeed you can work through the things that are happening with all of us during this time.
Thanks, Keris. Richard, I know that you've been on the front line throughout this and continue to work with folks. I was wondering if you could bring that perspective of the work that you've been doing during this time to help us think about the role of peer workers around COVID.
Well, for me, what was to my benefit and to also the people that I'm working with, a lot of the people that I'm working using Zoom and working over the phone is that some of these relationships I have already previously established. And so that's made it a little bit easier to connect with other people. But at the same time, and knowing some of the challenges that we all face, that they faced previously, and understanding that the isolation, what COVID has done, the isolation and the limited resources that initially we had, it had a lot of people nervous. I think that it's also, again, also made us show our resilience too. It's made us see that that despite it all, that we do have the tools and we do have the wherewithal to carry through and follow through, and just being supportive and being there for each other. I think that it took a while to get adjusted, and there's some things that we, and myself and including others, that thought that we had dealt with previously in our life, and that being in that isolation, being that we didn't have that initial connection, and being not knowing what was going to come, what the future would look like, it got us nervous, and some of those old habits and some of those things that we previously thought we had fought and let go come back to visit. That could be from addiction, or that can be from just not wanting to socialize, the isolation, and that's the ideal time for people who do like to isolate. This is like their season, so getting people who have just started coming to socialize and coming to groups and doing things in the community and being a full member of the community, this was like really a kick in the butt.
Thanks, Richard. I'm glad you brought up this point. People have had mental challenges in the past. Some of us are familiar with a lot of the feelings that everyone is experiencing right now. So some people may like isolation and being alone. Some people may have been isolated in the past because of different circumstances. A lot of us have experienced fear, paranoia, and other feelings that now everyone is experiencing together. You, I think, bring to our attention that maybe having gone through that doesn't really protect you from feeling all of it in great intensity right now. But I've also talked to some people who mentioned that the fact that they have gone through their journey of recovery before kind of prepared them for this, maybe a little bit more than other folks. I was wondering if you had thoughts on that, Thomas.
Yes, I think it's interesting what Richard said as well, because my first instinct is to say, hey, listen, you've been through something similar. It impacted you in a certain way. Maybe it took many years to adjust to it, but as in my case, as I hopefully believe these days, you're coming out on the other side of it. So you can look back and draw certain lessons from those experiences and apply them as something similar or even something resembling that comes up again, like COVID, the corollary between COVID and mental illness. But I think there's a whole other issue of triggers, too. which is all those feelings aren't necessarily located in the past 100%. They've evolved and they've been submerged and they reemerge in different ways as you continue on your journey. And something like COVID can definitely disrupt previous care patterns. Like Richard said, he was established with his clients to begin with. Then there's the technology that comes into it that's new for a lot of people to face and deal with. And so it can bring up certain experiences, certain feelings, wants, desires. People have potential for a relapse in there somewhere. My overall feeling is that there is a lot of wisdom in having gone through it before, but it doesn't sort of declaw or defang the situation.
That makes a lot of sense, Thomas. It also makes me think that how variable the experiences can be, not only from person to person, but I think for me at least, I feel like some of these fears come in waves. I feel like sometimes I'm doing okay and then suddenly not so much. So I guess the takeaway message from this is that people experience this whole situation in so many different ways, and even you as a person may change the way you experience it may change over time. I wonder if you had thoughts on that, Keris, about how people are experiencing this.
It's so funny. I actually do, and something that actually happened to me that I ended up writing about. And pardon me if my light goes on and off. I don't know what's going on. I guess it's getting hot. It goes on and off. So you get me in silhouette. But yeah, so that's kind of the resilience part. We just deal with it and we keep going. But the other thing is, what happened maybe within the first couple of weeks is I had a leak under my bathroom sink, and I didn't know it was going on. I didn't know that was going on until I had to change the toilet paper on the toilet paper roll. And when I picked up the bag that had like all this toilet paper in it, like I buy the like big 12 things, I don't want to run out of toilet paper. I picked it up and I'm like, this shouldn't be this heavy. Why is it so heavy? It was sopping wet. And I thought, oh my gosh, there's no toilet paper in the store, and I just started to go into like panic mode, then I started crying, and then I thought I kind of went into my life is over, this is devastating, I didn't plan well, all of these kind of things just rushed, and I literally I crawled into my bed and was just heaving, crying about this wet toilet paper. And then I realized something, that I am actually a person that is overly prepared, I will put it that way, and I was like, wait, you have 12 things of toilet paper in the trunk of your car. You have 4 things of toilet paper in your second closet. You have 6 things of toilet, because that's just kind of like my makeup that I did get diagnosed for. So it actually ended up working in my favor, that I had these things available to me. Now, what did I do still? I still put my toilet paper out on the balcony to dry. I live in LA. It's sunny. You could do that. So I was not going to throw away these things of toilet paper. But it ended up being kind of this reminder of something that could have really sunk me, didn't. And I was able to pull into those strengths, and even something that is diagnosed to me as a strength to get through the lack of having toilet paper. But I think what it also reminds me of is it was really interesting that, some of the people, we serve have said, well, I was in the grocery store and I ended up leaving the grocery store with 3 carts of stuff. And I don't know if that is my quote-unquote OCD. Is that my OCD? Is that my anxiety? What is that? And I said, well, when you were in the grocery store, did you look around you? What did other people have? What were other people doing? Dad, man, I had the least number of grocery carts. And I said, exactly. So you were in prep mode. This was not OCD mode more than likely. Or yes, there's a bit of anxiety, but that's pretty savvy to go and make sure that you have everything you need so that you don't have to go back and forth several times. So, and I said, always check with your treatment team if you really think that there's some other supports that you need to make sure. But I think that's one way to think about it. And again, sort of drawing on that pureness of not always going directly to symptoms and diagnosis, but pulling on the what about this when you look around you? Just stop for a minute and think here what was around you. And I had to do that for myself with the toilet paper after I had my moment. So, I think those are kind of two prime examples that I can think of.
Thanks, Keris. That's so interesting, and I think it brings us to a problem that maybe we knew was there, but I think it makes it clearer now. Some of the things that we diagnose as problems, depending on the context, can become solutions even. So I don't know, something that seemed quote unquote pathological, of maybe cleaning too much or hoarding things, or all these behaviors that we pathologize sometimes are now incredibly useful. So how do we deal with that? That the fact that this change of context is also making us rethink how we diagnose and how we think of symptoms. I was wondering, Richard, if you had any experiences around that with yourself or in your role as a peer.
Sure, of course I have. I know that the process for recovery has so many different roads that we all choose to go down, and one road is not one size fits all. That's not what recovery is. And recognizing that and realizing that that some of the challenges that I heard earlier when someone was stating that when the same challenge comes back to visit you, that you were kind of prepared and more prepared to deal with it. And that can be true in some senses, but it also can come at you differently too. And so I think that those old experiences can make you also go about doing things differently, about seeking different help, because one of the things that I've discovered personally myself is that what used to hold me doesn't hold me any longer. What used to take care of me doesn't. So there has to be, as an ongoing person through my own process, I've had to find other ways to take care of some of my own personal issues. And what answered me 10 years ago, it doesn't work today. So in terms of adaptability, in terms of understanding that that in the process of recovery, that the varied roles that are available I used to do acupuncture, and it would calm me down and chill me out. I can't get to acupuncturist right now. So, other things that I've had to do and to use in my toolbox. Not only with the resilience, but I think that myself and a lot of people that I've worked with and the adaptability and making even a bad situation work for them, an uncomfortable situation work for them. And also, I think that comes through also with, I call it my circle. And I think that comes also with the kind of support you have. And that, people who, as you go through challenges, and if you're open-minded and open-hearted, it should be, you might be willing to try something new that somebody else might have tried. Someone suggested to me a week ago, go to the beach. And I was all tense, and I went to the beach, and like the water just took, made me feel so much better, going when the water went out, when the tide went out, I felt relieved. So it's about being open. It's about being adaptable. But everyone doesn't have that luxury. And sometimes even for myself, we get stuck, But at the same time, that circle, when I get stuck, they'll pull me out of the mud, and have me really focus and examine whatever I'm going through. And so that way I also can share that with others, So it's been an evolving thing.
Thanks, Richard. Relationships are so important, and cultivating those can be incredibly healing, especially right now. I was wondering, this talk about how things shift over time and how there are many, different meanings to to different things and how they change. I was wondering, the other thing that seems to have changed is this idea of essential and essential workers. I think now more than ever it has become clear that some of the people or some of the jobs that were least valued in society are now we're realizing are actually the most important ones that we have, like people who work at grocery stores, people who drive buses, people who ensure that this, the city, the places that we work, and that everything keeps going. And I feel like COVID brought that to our attention. If we didn't know that before, now it has become incredibly clear. I wonder, Keris, if you could start and offer some comments around this idea of essential workers and non-essential workers and how, the whole peer role plays into that.
Sorry about that. And of course, I'm in the dark again. As soon as you call on me, I go in the dark. But this has been so interesting for me to hear this term, essential worker, and the pejorativeness of the word essential. It really struck me that for people who are traditionally marginalized, like peers, were not considered essential. When I would say, no, we are essential, we are important, we are valuable, we are needed, but the word essential kind of says, no, you're kind of next in line, if you will. And so I really struggled with it, especially in my work with the county, as did many of our peers and promotores as well, because it was like, yeah, we'll get to you kind of thing. And it's like, well, if you think about it, again, I think I started saying in the beginning, everybody is going through the trauma of this unknown, unseen thing that has now just affected our lives. And we can't see it, we can't, we can touch it, and then the next thing you know, we might be affected by it. Now more than ever, peers are essential to help people address the emotional roller coaster and things that they're going through during this time. We are essential to help the people we serve stay connected when the rules are please stay socially distant. We are all about social connection, so we had to reword things to it's about physical, sorry, I'm hearing things. It was about sort of physical, and I'm hearing things that are in the webinar, not I'm hearing things, but you know what I'm saying. So it's about, we want to be socially connected while we're watching our physical distance. And so we had to reterm things, we had to rephrase things, we had to help the people that are the providers, the policy people, understand things that they don't do because they don't walk our walk. It was like, yay, telehealth, we can expand telehealth now because it's needed, people can't come into the clinic, but there was no understanding that you could say you could do it. The federal government could reduce the restrictions on the provider side in order for it to be done much easier without recognizing on the consumer side, what if you don't have technology? What if you don't have a good data plan? What if you don't have bandwidth? What if you don't know how to download the app in which you're going to be using telehealth for? So the essential nature of our work really should have been hand in hand with the essential nature of workers who would be responding to the medical part of COVID itself, as well as the emotional part of the community, including those other first-line workers, such as grocery store clerks and mail people and all that kind of stuff. We're on the warm lines and we're helping those folks out. This is their first time. They're scared. Doctors have to make sort of these moral injury kind of discussions. Who's helping them? Our peers on the warm line. So I think that's really powerful about the important essential nature of peers with the rest of the workforce during this time that might have been missed.
You're so right, Keris, and I'm glad you brought to our attention the word essential and how sometimes language can reveal some assumptions that we have and that we really have to revisit. Thomas, I was wondering if you have any thoughts around this and how of this whole issue of essential, non-essential, this language that we've been using, and how suddenly with COVID it became really clear that the things we thought were essential are maybe not the things that are really needed right now. Do you have any thoughts around that?
Yes, I do. I have several thoughts, and thank you for asking. The first thing I want to say gets back to this idea of that pathological, so-called or labeled pathological behaviors and constructs and thoughts can actually be methods of success or transmission of lessons and wisdom. And the reason I say that is because it's kind of like a top-down thing, right? It's like, first off, what seems essential to one person may not seem essential to another. A lot of times it has to do with who is speaking for, who is walking the walk, like Keris says, and then who's making the decision about what's essential. And they're not always the same people. So it has to do, in my mind, with a question of understanding of the experience of others and of groups who are other. And that could be anyone from a grocery clerk can be other to me, or someone in a different neighborhood could be other, a person from another country, a different culture. All of that can speak of otherness, but we're starting more and more to listen to experience from us out, from our experience, speaking our truth to other people and being heard and understood. But I think a lot of the decision-making process that was going on vis-a-vis mental health, but also throughout society, had to do with a certain governmental and administrative procedure and flexing of what was considered essential and what was considered inessential. And I think that with the crucial issue I'm trying to get at is, where does the truth in the experience lie? Because as long as people are making the decision of what is essential versus inessential, and they're not speaking to that truth or walking the walk of the people involved, there's going to be a discrepancy there. So I think that discrepancy certainly exists. I think it's going to take years and years of activism to change that, but I actually think COVID-19 is an opportunity to do so, because it has us flexing our experience and our narrative, and it has led people to question that idea of what's essential. And I think that's our fundamental right. And I think if we can act on questioning and not just assuming, and that goes for the people who are making the executive decisions, governmental policies, down to the people who are reflecting on their own experience and communicating that to others, I think we might stand a better chance next time around. That's not a forecast of doom, but the idea is that who is speaking for whom, and I think there is a discrepancy there.
Thanks, Thomas. That makes a lot of sense. And Richard, I think part of this discussion of essential workers is related to some of the issues that we have been seeing around the disparities that COVID has also been showing us. I think when the virus started circulating and the pandemic started, people said things like the virus doesn't discriminate. And when we started getting the first data on outcomes and infections, we quickly began to see that Black people, persons of color, and Latinx communities were being way more affected than other communities. So I'm wondering, what has been your experience around that, Richard?
Experience and thoughts. I've noticed that it's funny just how certain things are viewed, and I always relate it to when they called, they said that we were having a drug epidemic, and a few years back, and people became super concerned, and so now with the COVID virus and coming in, and although the epidemic has been going on for 20 to 35 years in certain neighborhoods, there was no concern about it. And there was no cry out to get help or assistance to deal with it. And the disparities in the same way have been affecting certain people in certain minority communities. certain people, black people and brown people for a long time. And COVID has just brought it to a head where now we're admitting we see the disparities. But those disparities were already in place. This is nothing new. And so I've known it, and anybody who does any kind of medical care or mental health care, we've been aware of it. I think that with being a peer, and when you're saying that this is our time to be, that we're working as essential workers, and I mean, we've always been essential workers. We've always had that role. We just weren't regarded in that role, and we weren't treated in that role. And so because of the relationships that we have, because of our own similar lived experience that we share, that it is essential that we connect with someone that we can relate to. It is essential that we talk to someone that we feel we have a mutual relationship with. And so when this came along, although we weren't regarded previously before that, we took our place and we followed through on it. There's a lot of people that I work with and talk with and share with that couldn't get in touch with their clinicians, couldn't reach out to certain people that weren't available. I mean, we went through a whole legality of rules and regulations of how we were going to connect with people, and it was like a long time, all these challenges where one had to get this word from this person and that person, and it was a hard situation to initially when we tried to start doing groups and using Zoom and things like that. And I was able to get approval to move on and connect with the people that I was previously been working with. So I think that when you say essential, I think we've been essential. When you talk about disparities, there's been disparities. It's all of this stuff that just came to a head because of this situation. And I'm just hoping moving forward that we are looked on in a better light and understanding that we are essential, and so that we are connected. And we are one of the first people that a lot of people connect with.
You're absolutely right, Richard. And I'm glad you reminded us of several other instances where this happened, such as the opioid crisis. That had been around in the community for a long time, and then when it started affecting other communities, it suddenly became a public health problem, whereas in other instances it was a criminal justice problem. And right. So I'm glad you're bringing these contradictions up. I think that everyone who has experience, lived experience with this, knows that these issues have been around and that the disparities have existed forever. But in this moment, it seems that they have become so evident that it's really hard to pretend that they're not there. A lot of them we can think of in individual levels, but most of those are highly systemic, as you've been talking about. The different ways in which systems go ahead and make sure that telehealth happens for the medical community, but doesn't do the same with peer workers. And so I'm thinking that, it's now becoming maybe more difficult to deny that these disparities are there. But I also remember hearing you speak recently, Richard, about, a lot of people have been saying we have to discuss this more, we have to talk about it more, but you always say we have talked about this so much, it is time to do something. And I was wondering, Keris, did you have thoughts to offer on this issue of how these disparities have been around historically? Now they seem to have become more clear, but still, we don't see immediate changes that would directly affect these more systemic issues that have been around for a long, long time. I think you're on mute.
Yes, sorry, my light is being all persnickety again. But Yeah, I cannot say enough about how this particular time, as times before, sort of really magnify the disparities and systemic and institutional issues that affect communities of color and marginalized communities. And one of the things about the peer workforce, and for folks, I know most folks may be on the East Coast, so I can say a little bit about LA. Being very, very diverse. It's a county of 10 million people. We have over 13 threshold languages. And so our peers look very much like the communities we serve. We are of and from the communities. So we do not have enough providers, quote unquote, I would say your conventional providers, licensed providers, who speak all of these threshold languages, who are from the communities in which we are serving. So it has been super important that our peers are there and able in language and cultural ways to meet people where they are, help them understand what's happening, get them the public health information and the emotional support information in ways that have never been done before. I mean, we had to get creative real fast. You know, talk about pivoting. I mean, yes, we're very flexible. The word we've been using is pivot. We had to pivot how we do what we do to ensure that the best that we're able to address the disparities that we knew were there. And it also kind of brings to bear, at least as I think about it, the strong role of advocacy that peers can have as well. When we understand that these are systemic and institutional issues, many times driven by policy and funding, collectively we have a voice that we can bring forth and be examples of like what is needed in order to address some of those systemic issues. I think you know, one of the things, and you know, people may know we don't even have peer support certification yet in California. We're still working on it, and that is the very thing that we're saying is that you know, as part of what we're trying to do in addressing these, again, systemic issues around homelessness, criminal justice involvement that impact communities of color, Black and brown people, Native American folks in particular, you need our wisdom to understand what it does to emotional health, what it does to our emotional well-being, our ability to participate and contribute back to society, that you need this workforce to help people in their communities in ways that we can meet them to move forward in our well-being. So I don't know, that was a mouthful. It's just, it was really hard initially because I did keep saying, wait a minute, guys, we need to think about how we're doing and how we're communicating what we're doing to communities in ways that they can hear it, receive it, and access it. It can't be one message. It needs to be messages that are targeted for each of these communities in ways that they can receive it. We had to do things like digital health literacy. We created a whole digital health literacy curriculum. So as soon as people got access to the technology, we helped with doing that. We had to help them understand how to use it. You know, again, there's that digital divide that greatly impacts our communities of color, and they've got kids at home trying to do their education at home with low bandwidth, no bandwidth, and then when they got the computers, they didn't know how to use them. That's not a mental health issue. Yes, it is. It is a mental health issue. It is an emotional well-being issue. So we really had to work very hard to ensure that we found our place in being as responsive to our communities as we could, and we know that the job is not done. It's going to be a long haul, but we were able to be active and do something while we also talk about it, because a lot of us were tired of the talk as well.
Yeah, Keris, I mean, that was so powerful, and it reached, I guess, so many different points that are important here. I think one of the things that you mentioned is that peer work is really not restricted to mental health issues. The fact that peer workers exist in the system makes it possible to push the envelope on several different fronts and not exclusively on mental health. And having those voices present within systems is really something that often enables systems to be responsive to the actual needs of the communities and not to the imagined needs of the community. So I think you touch on a very important piece right there. And along with that is this idea that maybe if you're looking from your own perspective, you would think that by simply handing out devices like computers and telephones that would be enough. But if someone doesn't know how to use them, then what are they going to do with those devices? So it's not just a matter of getting resources, physical resources to people, but also how these resources reach people and how do we build knowledge around how to use those things. So it's just, the issue is a little bit more complicated than just getting access or just, you know, giving devices to people. And I think you bring that complexity to this conversation. And I'm thinking, Thomas, that this touches on some of your interests related to cultural legibility and, you know, this idea that peer workers, this, you know, more narrow idea that peer work is related to mental health and that there's a very specific issue that they handle, but also what Keris is revealing and what she's saying, that actually peer work has a much larger impact within the system and communities and in a much broader sense than strictly mental health. Do you have any thoughts around that?
Yes, I do, and I agree with Richard and Keris on this issue, and you, Anna. And I think that the first thing that I'll try to emphasize is my personal belief, and I don't say that to be ironic, but is that it's an ideological shift. That there's an ideological shift that needs to take place in terms of how we understand the experience of others. And when that ideological shift can take place, and it has to take place throughout the culture. So no, it's not just limited to mental health concerns or the role of peers within the mental health system. It's an ideological shift that encompasses many issues, many platforms, many progressive ideas, and many aspects of necessary change that needs to take place. And of course, along with that, doesn't just involve locating resources and distributing them. It's an educational process. It's a training process. It's a positive indoctrination process. It's an enthusiastic and it's an encouragement process. And I think that it definitely has a role to play within the mental health care system. I think it's crucial for patient care. It's crucial for our evolving understanding of mental illness and recovery from substance abuse as well, and that's part of the cultural literacy I speak of people with mental illness and addiction issues. But it's part of a broader change in ideological shift in our culture that has to do with how we listen and treat and educate and respond to others. And I think the very concept of peer work and the role of a peer can be very expansive in all those areas. And I ideally see this taking place so that there's different versions and instances of peer work going on at different levels and in various scenarios in different arenas in theaters within our culture. And I'd like to think they'll always stay tied to and owe something to mental health care in that scenario, but expand far beyond there.
Thanks for your thoughts, Thomas. That's very true. There is a need for a broader cultural shift, although sometimes it, especially in political moments such as the one that we're living right now, and I say that as a Brazilian person, how much the political landscape has changed in recent years, and I think you make a great point around how important it is to talk about this, in a broader sense, and not only stopping at the system level, but also think about it culturally and what the representations around mental health issues and other issues related to that are thought of. Richard, I was wondering if, this issue of acting and not just continue to discuss and talk endlessly about a subject, whether you have thoughts on that. How should we be acting right now, and what do we need to be questioning at the moment?
Through all this experience, the experience that we are going through as a people here, with the COVID virus, as well as with the racial tension and the outright killings that we've seen, and the mood that everyone's feeling in terms of not feeling safe, not feeling a part of, and really feeling confused. And so I know that the isolation and all the other things that it's come with, and the challenges. I mean, I've been to 5 COVID funerals since COVID started. And these are friends of mine's family members, and who died alone. And so there's that mental health issue of not being with your loved one as they die. But in all of that too, again, resilience. But I was just blessed yesterday to be on a roundtable call for the Yale Psychiatry, and they were talking. And this gentleman, I guess he was the director of one of the hospitals there, and he spoke and shared how they prepared for the virus, how they prepared rooms and floors, and how they made it an urgent response to do something, that they weren't waiting around for it to hit. They got prepared. And I'm wondering and I'm saying to myself, then why aren't we using those same techniques in terms of the health disparities, in terms of the race relations and the issues that we're facing? That they're not something that we can just put on the shelf and say, we'll get to it, or it's going to take care of itself. We should be having a reaction plan, and we should be implementing that and doing that and following it and sticking to it. And so I just think that, and when he said that, it clicked in my head. If COVID was an emergency, and some of the things that we're going through are emergencies, why haven't we adapted emergency techniques to go ahead and deal with some of these things? I'm not the sharpest knife in the door, but I'm just trying to get an understanding that why don't we use the same attitude, the same spirit of that? We prepare for these things, and we don't wait for it to bubble up and fumigate and we react to it, and we react to it in a conscious, constructive way. And I just don't see all of that happening. And that's what kind of bothers me, is that we can sing Kumbaya all day, and that's not getting us anywhere. Until we deal with the issues and be honest and straight up, nothing's going to happen. And so we come up with a plan that we initiate, and that comes from the head. That comes from people who are in charge, who are the leaders. That comes from them. The body won't do nothing. The head don't tell it to. And that's the bottom line for me, as a peer, as a human being, honestly.
You're so right, Richard. I think that one of the most infuriating things that are happening right now is that we seem to have all the resources in place to respond to any of these issues, and we're not responding, or we choose to respond to certain things and not to others. So I really resonate with what you're saying. It was suddenly very possible to come up with a very quick response plan to this pandemic, but what about these issues that have been around for, centuries in this country? Why can't we respond to them? So I really resonate what you're saying, and I think that that's a great question to have in mind. What's motivating us not to react to that? And with that, I'd like to take a couple of questions from the chat. Is incredibly vibrant, and we have a lot of comments, and I really wanted to engage with the people who are joining us today. And so I was wondering if we could go ahead and start taking the questions and comments that are being put in the chat. So let me start. I think there are many folks who work for who are peer workers, if I'm understanding correctly, and I'm really glad that is the case. There's one question that I think is very important. can someone give a reference to how HIPAA has been changed with COVID? And I think that really touches on, you know, how things shifted for medical care and then how that shifted for peer work and how those things were not, you know, the same. Keris, I wonder if you have information or knowledge about that you'd be willing to share with us.
Yeah, it won't be, I'm not going to turn my camera on so you can at least see my face in the light there. But for the telepsychiatry, and we'll call it telepsychiatry, telehealth in particular, the regulations around telehealth, privacy, platforms, where to do it, how to do it, et cetera, those are all federal guidance through the HITECH Act, HITECH, H-I-T-E-C-H. And then mental health, I think, and substance use came after the HITECH Act, and I don't remember the name of it. But what the federal government did, I believe, in the CARES Act. There's a CARES Act and there's a CARES Act, and I get them confused, but I think it is the CARES Act. They reduced a lot of the restrictions for platforms that can be used to provide telehealth. Meaning Zoom wasn't one, for example, it is one now. You couldn't use FaceTime, you can now. Like those types of things were reduced on the provider side. So can peers do that? Yes, they can if their agencies or wherever they work have aligned their platforms to those new regulations. For example, in LA County, we cannot use Zoom. And that is by choice of LA County and their mandate, even though the federal government says, yes, you could do it. But we don't feel it's secure enough for whatever reason, so we don't use it. So we've agreed with other platforms. So that's how that kind of works. What it didn't happen is literally on the consumer side, meaning the person who is the recipient of the service, if there are lots of restrictions like for the Lifeline program. So if you know the quote-unquote Obama phone, that is the federal Lifeline program, and that has lots of restrictions around data plans, internet speed, how much internet you can use, and that becomes something where especially people living in poverty, people that were serving in public mental health, for example, they're going to have limitations and they're going to have to make lots of decisions. If I've got kids at home and I'm only allowed one internet plan for my household on the Lifeline program, I have to think about, well, what do my kids need before I can figure out then how much can I use before I run out of those minutes to do my appointments or make my phone calls. So there has been advocacy with the federal government, with the FCC, who oversees the Lifeline program, around reducing those limitations, especially during state or national disasters as a start. So you can find that if you Google FCC, Lifeline program, advocacy, that kind of stuff, you can actually find lots of work on that. And then there's another act that followed, the CARES Act. And this is where like people are getting the extra money and things like that if they're out of work within the CARES Act. And the HEROES Act, which has not been signed yet by the Republican side at the federal level, the FCC limitations for Lifeline are actually in that act and they have not been acted upon. So that's where you need to look as well. Sorry, I'm a bit of a policy wonk. That was probably really long, but I'm really adamant about this digital divide, and the longer it remains divided, the harder it is for people to catch up, to be a part of, and to be fully having access to what everybody else has access, and it affects our folks particularly.
Thanks, Keris. That shows how knowledgeable you are around these issues, and I agree with you that they're incredibly important. And your work is also have been really important in that area. So I appreciate you clarifying some of these things. But I also wanted to give you an opportunity to maybe respond to some of the comments that Richard had around these structural issues that have been around for a long time and how we were able to react immediately when COVID hit, but it seems like there is a lack of political will to respond to issues around marginalized folks, Black communities, Latinx communities that are there. And it seems like we have resources to respond to something like COVID, but I wonder why we're not responding to these issues that have been around for too long. Keris, did you want to?
Oh, okay.
Yeah, I was just thinking if you wanted to. No, I'm sorry. I was just thinking if you wanted to respond to that.
Sure. I think there's always this thing called political will, and I think we're sitting in an interesting political time from the place in Washington, D.C., for lack of a better way of putting it, that there has to be the political will also to make it happen. So I think there's always a top-down and a bottom-up approach to putting that pressure on. And sometimes, and because I did work for the federal government, I think the other thing I learned is what's the workaround? While we're working on the political will, we have to have the workaround, and we have to commit to that workaround. And, you know, even in my work, you know, in the county, it's like, okay, but what's the workaround? And it's sometimes like, well, just kind of do it and see what happens and see if you get in trouble. You know, if I didn't break a rule, you know, and I was able to kind of like make it happen, well, then just make it happen, and then people will jump on board. And I think that's exactly what happened. I saw people talking about, for example, you know, even older adults and older adults' ability to either access or utilize the technology. You know, we trained, you know, they're called not system navigators. We have so many names, but they're basically peers who help our older adults. And we did a special training for them so that they could actually then be next to those older adults, supporting them in using technology, learning how to use the technology, et cetera. For Latina and Latinx communities, again, we have a large cadre of promotoras. I mean, of our population in LA County, 48% is Latino. I don't know what percentage of that is also monolingual, but we are quite aware of the monolingual needs for folks. So, you know, we don't have to translate. The thing is already in the language because they're already doing it. And we try to spread that wealth. We've created like virtual communities of practice and things like that. So it doesn't stay within us, that we try to find ways to share it, at least with our LA County community and sometimes with the state. So, and we're not, I think people think, oh my God, you guys are so big, you're so rich, but we're not really. We're a very, very large county, 10 million people, all the way from rural to urban to suburban. It's very big, and that also makes it kind of hard sometimes to do this work because it is so big.
Thanks, Keris.
You know,
go ahead.
And Keris, I thank you for your knowledge. I appreciate it. I think that you're well informed, and I really get a chance to really understand the laws and the political takes, the political atmosphere that's in our country right now. But I get that. I do get it, and I understand that. But I think, and Anna, from where I'm sitting, it just seems like people who are in charge and people who knowingly know that things are the disparities and know that things need to change. If we have to wait for the politicians, we'll be holding our breath forever. I think this is the part, this guy is making a comment, is like going about pounding the pavement and getting the word out. I think we and people that are in power and people who run things have that opportunity to do that ourselves. We can change this thing if we take responsibility and take a hold of it, take the reign of it, and make the changes. I mean, and like it's like she said, we start small and we do it and just try to test it out and see if it works, and that brings a change. Either it works or it doesn't work. But instead of not doing anything at all, we're activists. You know, this is what we do. And so, I mean, it seems that those in leadership roles, those who run things, would be, you know, have some guts to just go ahead and try it, you know, and have that support as a team. That's what I like to see.
Richard, you're giving me goosebumps, like quite literally, because that's where the power is. And I think sometimes we yield the power to the legislators and those elsewhere, when really it is about the people on the ground who make the movement happen. And sometimes the legislators and all those follow after, but sometimes, you know, and he is one of my heroes, and it was kind of sad. I was supposed to do something with him, and he passed away, but, you know, Representative John Lewis said, you know, you need to be good trouble and necessary trouble, and that's what that pounding the pavement is. That's what's taking that chance on doing something is, because, and I think that has been historically and continues to be what the peer and consumer movement, ex-patient movement, et cetera, has been all about. It's not about accepting the status quo. I think the small part that has been missing, well, no, it's actually a big part, I'm sorry, that has been missing from the consumer movement is being able to wrap our heads around and address, I'll just say it straight up, racial discrimination. Historic and institutional discrimination for black and brown people. We did not choose to come here. We did not choose, I'm also Muskogee, a member of the Muskogee Nation, you know, they took our land away. And on top of that, part of my history is, you know, yes, slavery and being enslaved even within the Muskogee Nation. So that is a very different experience that gets in your DNA. Nobody can tell me, oh, that was 200 years ago. Get over it. I can't get over it, right? And I think that's a space where all of us can really say we have to double down and really address these issues, because nobody will move ahead if black, brown, and red people do not move ahead. We'll always be left behind, and there'll always be these disparities and gaps. And we think we're fixing a gap, but that is the gap. And so I really can't stress that any more strongly, I think. And I think certainly COVID and the racial injustice things that are happening currently have really just put this ginormous magnifying glass on showing us where our way forward is and the work that we could be doing.
Right on.
Thank you, Keris and Richard, for bringing that to the fore. I agree that this is a time for political activation. I feel like this type of work and the work that peers do is so connected to the power that advocacy and really pushing the envelope and the things that can happen from the bottom up, let's put it like that. And I agree with Richard that if we wait for politicians to do something about this, we might be holding our breaths forever. So I really just wanted to second and resonate that. I want to get to some of the comments that are coming in through the chat. There's some really interesting things. Here's one comment from Kathy that they're working with moms and dads of children and with infants, toddlers, and adolescents, and the stress that has increased, especially in those in substance use recovery. And they're saying that they've become very creative with social distancing and currently have beach chairs and umbrellas to meet with the children outside. And thanks, Kathy, for that comment. And I was wondering around this topic, Thomas, of becoming creative. I know that when the pandemic first hit, you were mentioning how connected you were online and the different ways that you found to stay connected to people and stay engaged in the work that you do. And I think that this issue of creativity and finding new ways maybe to move forward is so important. I wondered if you have comments on that, Thomas.
Yes, I most certainly do, and I think it gets back to the nature of what Keris just said about virtual communities, but it also gets back to the nature of what Richard said originally about having pre-existing connections and interactions with his client base. And so my personal experience was that I was not always a big internet user. I had a very small Facebook page. I was not into it. And over the course of time, I saw what it did for some people who were influential in my life, other artists that I had worked with. And I began to, at a time when I was feeling kind of down, I began to pull it out of the box and explore it, and I built what I guess is called a virtual community. And I built that for myself, and right away I noticed it had a lot of therapeutic results. And I know that social media is a commercial thing, but to this day, when I was at Fellowship Place in New Haven, I did a project on providing blogs and websites to people with mental illness for them to use and express themselves creatively on the internet. And throughout my experience, I strongly believe that these different social media and also the internet as a whole, not to just be reductive about it, but it has therapeutic value. But then I like to say I built that community before COVID. So in the early days of COVID, I wasn't particularly sidelined because I had that community. And I kept using it and progressing with it for months and months. And sure enough, it brought me rewards that were tangible in nature and thus affecting my mood and my outlook. I am not as well educated about computers and the internet as some people, so there are lots of things I can't do, and I need people to teach me that, and so I feel that gap there tremendously. But I would say, in response to the question in the chat, for people in rehabilitation from mental illness or addiction, this idea of a community, precisely because a virtual community interacts with the real-time community. There's a continuum between them. So it's virtual, but it provides real emotional and tangible benefits and connections. And I don't want to go too far down this road because I'm not actually an expert at it, and I know there's a lot of conflicting research and scholarship. But I strongly believe that these virtual communities on their own, even during normal times, provide tangible therapeutic and rehabilitation benefits, and that during the time of COVID, if you have that in place, your experience is going to be very different from someone who does not have that in place. And I think it's part of the evolving meanings of mental health care, peer work, sober living, that can expand into so-called everyday life, but also areas of policy change, also areas of activism. We can't get the word out unless we use internet platforms. We're not just going to go door to door. We're going to do blasts. We're going to create websites. We're going to network online. And we can't get the word out unless we're doing that.
That's a great point, Thomas. And I feel like this virtual community can also be a point of political activation. We know that many of the protests were organized through there, and many, this is also a way to stay connected, even though we have to be physically distant. So thanks for that comment. That's very important. And I think a question just came in the chat that I believe this is a question that keeps popping up, and I think it's important to address it. And it brings us back to the racial issue, the discrimination, and things that and social justice issues that we've been discussing today. So Kathy is asking, as a white woman in recovery and a peer specialist, not ever being able to walk in Black people, Latinx, and Native Americans and other races' shoes, what can I do, or what can we do as an organization to advocate for these specific races? And I would add ethnicities or different, just different maybe nationalities even. So I'm wondering, Richard and Keris, you that have a lot of expertise and experience in the advocacy field, and that have been incredibly politically active around that and sensitive to these racial and social justice issues, if you could take on this question. Richard, did you want to start?
Sure, okay. It's funny because in our training as a peer, there were 4 things that came up. There was connection, mutuality, worldview, and moving forward. Those are 3 parts of being a peer. Those are things that we have to do in our connecting with people. And so I think that when you say in other races' shoes, I don't think it's even about being in other races' shoes. And when we know the injustice and when we know that people aren't being treated as human beings, that right there tells you, I don't know if you've ever been subjected to just even for being a woman. That there's isms and that is too. There's sexism. But the thing of it is that as an organization and as an individual, when you see injustice, don't just be quiet about it. Speak up about it. And I mean, I think that because not saying anything at all is putting a stamp on it and saying that it's okay with you. And I know that in terms of not only just as an African American man, but as a gay African American man, and as a person that has endured isms against them. I've had racism, sexism, and homophobia thrown at me, so I'm well experienced in all that. So when I see others go through it for whatever reason, maybe because they have long hair, or maybe because people think that they've been privileged and they're doing bad now and they should be treated like crap. I try to speak up for the underdog. I try to treat people like human beings. And anytime that I see anybody being disrespected and hurt intentionally, I speak on it. So I'm just not comfortable. It doesn't make me feel right to see someone else go through some challenges that I know is based on somebody's stupid opinion or idea of who this person is based on their race or sex orientation. So I won't be comfortable being around that, and I'm going to speak on it. I just speak on it. Unacceptable. So it starts with self.
Thank you, Richard.
Yeah,
Oh, go ahead, Keris.
Oh, I'm sorry. Yeah, I'm going to add to what Richard was saying because it was so powerful. I find myself many times, being the one who is the lone this or the lone that, whatever it is in a room, and I have to speak up when I hear something that is, let's say, disparaging or not quite right, because maybe somebody didn't mean it to be so, maybe it was implicit bias or what have you. And then I leave the room and somebody will say, oh, thank you for speaking up. And it's like, it's such a burden to put on me or anybody else alone. So there is, I think, a boldness, and I'm not a super duper outspoken person. Oh, okay, maybe I am, but I'm not. but I think that's hard for people to kind of. It is hard to kind of speak truth to power or find a way to bring up something when we feel it's not appropriate, right, disparaging, or helpful. Or even to question, well, gee, is that what would be helpful for this person or this group? Or I've heard that this isn't helpful. How are we going to address it? So I've even found ways, especially as I would call as an inside advocate, meaning I'm sitting inside the organization trying to impact change, that I've had to figure out what strategy works best when I'm sitting at the table. And as Shirley Chisholm said, if you're not sitting at the table, bring your own folding chair and get up and sit at the table if there's not one there for you. But I found sometimes it's just by mere nature of asking the question, begging the question. Is this, what about, what if, I've heard, how are we going to address, versus saying, stop doing that, that's not right. That is very hard sometimes for people to hear. So I've had to switch it to reduce defensiveness in order to open up conversation and exploration and reduce a feeling of shame and blame for the person who may be receiving that message, where that kind of shame, blame kind of thing, they call that white fragility nowadays, I guess, might come up. But I also think that all of us, no matter what skin we're walking in, have experienced a time when we have been made to feel different and not in a good way. And if we can tap into that, what would we have wanted somebody to do to help us? What would we have wanted to do ourselves to make something different? And I think if we can kind of start there as individuals, it can help us think about what it is that we can do in our own space and role within our either organizations, our communities, or as individuals. Sort of what I think about as well.
Thanks, Keris. I think you bring, I just wanted to resonate what Richard and Keris are talking about. And I think, Keris, you point to something very important, which is that the burden of pushing these conversations forward falls on the very people who are victimized by everything that's happening. And so that is exhausting. That along with feeling the discrimination on a daily basis, you are also the person who's responsible for pointing that out and for doing it in a tactful way to not hurt other people's feelings, and that feels like a lot, you know, on the very people that are being victims of this. And I could offer some of my personal experiences related to that. As I mentioned before, I'm Brazilian, and I'm not a citizen of this country. And so every time, and then Richard, you know, you're my role model, and every time I hear you speak out, and I know that you're never, you never take it home with you and stay quiet. You're always speaking out, and I just find that so inspiring, because I still can't do that. I'm always afraid. I'm here, I'm in this country as a kind of a visitor. I have a visa, so I don't have the same rights as other people do. And then recently there were threats on the very visa that I hold. So, you know, from one day to the next, you may think that you're going to be deported from the country where you work and live. None of my family is here. The borders to Brazil were closed. And so I can't go back to my home country at the moment because I wouldn't be able to come back here for my work. And so all of these experiences are things that you go through alone, and no one really knows what you're feeling. But then recently I had a situation when someone said that one of the problems to move forward with something was related to, you know, having so many foreigners around. And the way that struck me, and that was the first time I was directly affected by something like that. That had never happened to me before. And just hearing that just hit me in such a powerful way, and I got completely paralyzed. I wasn't able to speak up in the moment, and I was really scared of what the reaction of everyone around me would be if I did speak up and said, well, this seems to affect me directly because I am a foreigner, so, you know, why is this happening? So I think that the burden of, other than being victimized, also being responsible for bringing all of these questions up, I think that is a lot. And I feel like we all should be taking more risks, maybe, and not leaving the job of speaking up about these things exclusively to the people who are directly affected by them. So I just wanted to resonate with what you said and say that perhaps we also need to share this burden a little bit and take more risks as we speak up, just so that, you know, all the work and the burden doesn't get left to the very people who are victims of this. And I'm mindful of time. We have 5 minutes to wrap things up. I found this to be an incredible discussion. I've learned so much today, and I had the pleasure to share the space with 3 people that I admire greatly. And I just wanted to thank you for the work that you have been doing and for sharing the wisdom that you have accrued with all of us. And say I apologize that we hadn't had the chance to get to all the questions and comments that were in the chat, but that we read them carefully, and we really appreciate that you engaged with us so much today. And with that, I just wanted to let you know that in 24 hours, you're going to get a follow-up email with a recording for a recording of this webinar, and this will also be available on the MHTTC page. And so stay tuned for other events that the MHTTC is hosting. And I just wanted to take a moment to thank Thomas, thank Keris, and thank Richard for this amazing conversation. And I think this will have a great impact. And I'm really grateful for you sharing your wisdom with us today.
Thanks, Anna.
Thank you, Anna.
Thank you.
What a pleasure. What a pleasure.
A huge pleasure. Thank you, and goodbye, everyone.
I'm waving, though you can't see me.